Look, you've put in the hours, you've read the chapters, and now it's time to pull the whole shebang together. Welcome to this final review explainer. We're totally bypassing the basics today and zeroing straight in on the absolute highest yield cross-topic points. The goal here is simple. We're going to help you beat those classic exam traps and recognize the incredibly subtle clinical red flags that actually save lives. Here is the roadmap for our rapid-fire summary. We're covering critical neurologic emergencies, brain infections and trauma, tetanus versus botulism, APSGN versus nephrotic syndrome, and finally, Wilms tumor versus neuroblastoma. Let's untangle these. Starting right off with Section 1, critical neurologic emergencies. We're jumping right into the deep end to grab your attention. This is your ultimate do not wait scenario. If you see any combination of a fixed, dilated pupil, abnormal posturing like decorticate or decerebrate rigidity, or Cushing's triad, herniation is literally imminent. This is absolutely not a let's monitor and recheck in an hour kind of situation. The provider has to be notified immediately. Now, you might be wondering about how Cushing's triad is actually tested. Well, there's a relentless exam trap here, and it's relying on bradycardia alone to diagnose increased intracranial pressure. You just can't do that. For it to be the true triad, that bradycardia has to show up with hypertension or a widened pulse pressure, and it must appear with irregular respirations, all while the patient's level of consciousness is actively declining. Let's move into Section 2, brain infections and trauma, and see how our critical thinking builds in our first versus round. Okay, so a child presents with a suspected neurological infection. This right here is the very first crucial question you have to ask yourself to figure out what you're actually dealing with. There is a hard line separating these two commonly confused conditions. Meningitis is an inflammation of the coverings, right? So it heavily features meningeal signs, nuchal rigidity, and positive Kernick or Brudzinski signs. Encephalitis, on the other hand, is an inflammation of the brain parenchyma itself. It fundamentally alters the actual brain tissue, which presents as an altered mental status or massive personality changes. For trauma, you really need to anchor the difference based on the source of the bleeding. An epidural hematoma is an arterial bleed, meaning it's expanding rapidly under really high pressure. A subdural hematoma is a venous bleed. And because it's venous, it's slower, it's a lot more insidious, and it typically has a delayed onset of 24 to 72 hours. Listen to this one carefully, because it's a massive red flag. It is a critical reminder not to let your guard down just because the child looks totally fine right after a head impact. That lucid interval is a complete trap that immediately precedes a rapid, life-threatening decline. Section 3, tetanus versus botulism. Let's pit these two really dangerous neuromuscular disorders against each other. I want you to hold these two together in your mind as absolute functional opposites. Tetanus blocks inhibitory transmission, so it essentially locks the body in severe rigidity, usually starting right at the jaw. Botulism is caused by a toxin that blocks excitatory transmission at the neuromuscular junction, so it does the exact functional opposite, progressive weakness and total flaccid paralysis. Which brings us to a relentless safety warning you've probably heard a million times. Never, ever give raw honey to an infant under 1 year old. Why? Because their GI tracts just don't have the acidity to destroy botulism spores. Those spores can colonize in the gut and lead straight to that terrifying flaccid paralysis. Moving to Section 4, APSGN versus nephrotic syndrome. We are shifting gears to the renal system to untangle two super commonly confused kidney disorders. This comparison is an absolute lifesaver for last-minute cramming. Acute post-streptococcal glomerulonephritis, or APSGN, is an inflammatory process triggered by a recent strep infection. It features prominent hematuria, so think tea or cola-colored urine, along with hypertension. Contrast that with nephrotic syndrome, which isn't about inflammation, it's a permeability issue that allows for massive protein loss. So here is the real professor insight you need in your back pocket. Hypertension is a surprisingly rare finding in nephrotic syndrome. Blood pressure is actually usually normal or even slightly low. The classic trap is assuming that blood pressure is going to spike just because there's massive proteinuria. It doesn't. And knowing that perfectly separates it from APSGN on any exam. Section 5, Wilms tumor versus neuroblastoma. For our final section, we are tackling pediatric oncology and the absolute most emphasized safety alert in this entire unit. So both of these conditions can show up as a painless abdominal mass in a young kid. The big question is, how do you actually tell them apart? Let's break this down. Wilms tumor arises directly from embryonal kidney tissue and is usually unilateral. It sticks to one side. Neuroblastoma stems from the sympathetic nervous system. That means it can pop up wherever those nerve cells exist, whether that's the adrenal gland, the retroperitoneum, or even the head or neck. But the single most important distinguishing fact here, it's a pretty sobering pattern. Neuroblastoma has usually already metastasized before it's even diagnosed. That paints a completely different, much more urgent clinical picture compared to Wilms tumor. And here it is, the single highest yield safety point of the renal unit. Never palpate an abdomen if you suspect a Wilms tumor. Because the tumor is encapsulated, poking around carries an extreme risk of rupturing it and spilling cancer cells everywhere. It is a strict, non-negotiable, hands-off finding. Okay, let's look at the traps here. A classic mistake is forgetting this never palpate rule during routine everyday care, like bathing or just repositioning the patient. You also have to avoid the trap of assuming every palpable mass is a Wilms tumor. And finally, never assume a neuroblastoma is less serious just because it seems like just a mass. Like we saw, it's usually already widely spread. Understanding these really subtle but absolutely critical differences, knowing exactly when to escalate care and spotting those red flags, that is exactly what's going to make you an exceptional, life-saving clinician. Take this structured knowledge right into your exams and your clinical practice. But ask yourself this: the next time a child presents with a simple headache or a generic abdominal mass, will you be the one to spot that subtle red flag before it spirals into an irreversible emergency? I know you will. You've got this, and I'll catch you in the next explainer.